Yeah, we'll start. Yeah, good afternoon. So we hope that you had a good lunch at your residence because of this COVID-19 pandemic. We could not provide lunches, all those things. So sorry for that. But definitely the next year Hyderabad will host with the physical conference. Definitely we will provide lunch, all gala dinner, everything. And welcome to the post-lunch session. So we have post-lunch session is the HIV and AIDS session. For this, I invite the session coordinator, Dr. T. Satyasri. So over to Dr. Satyasri.
Good afternoon, everyone. Thank you, Bhumesh sir, and all the organizers to provide me this opportunity. So, welcome to the session 3, HIV or AIDS session. I call upon Dr. Ram Manohar Rao sir. He is from Tamil Nadu.
Good afternoon. Good afternoon.
Good afternoon. And he got Sri Satyasai Dhanvantri Award and Chaco Valarappa Award as the best outgoing student from Madras Medical College. And next I call upon Dr. Tarun Mittal sir. He is a senior consultant at present from Synergy Institute of Medical Sciences, Dehradun. Welcome, sir. And he's got Uttaranchal Ratan Award in 2018. Yes. Next chairperson is Dr. Deepak Shirbata sir.
Shirbate.
Deepak sir, and he's practicing from Maharashtra. Yeah. And
over to chairpersons.
Over to the chairpersons, yes.
Good afternoon. At the outset, I'd like to thank Team Asticon for having given us an opportunity to be a part of the faculty. I would like to invite Dr. Manju Bala, who is an MD PhD. She has been a former HOD at the Department of Medical Microbiology, BMMC and Safdarjung Hospital. She has been a former DDG in the Ministry of Health and Family Welfare and Assistant Director in HOD, Department of Microbiology, Delhi. She has been a recipient of several awards, and she has also achieved several things. She has been an advisor on STS with WHO headquarters at Geneva. She has got a lot of publications, around 127, of which 59 have been in international journals. May I now request Manju Bala to proceed with the presentation, her topic being present guidelines in the diagnosis of HIV/AIDS in children and adults. Madam Manju.
Thank you, Dr. Rao, for your kind introduction. Good afternoon, everyone. And at the outset, I'd like to thank the organizers for giving me this opportunity to talk about present guidelines in diagnosis of HIV and AIDS in adults and children. So I will be mainly concentrating on what NACO has advised at national level. That is for diagnosis in adults and children beyond 18 months and in children less than 18 months.
We are unable to see your PPT, ma'am.
You are not able to see?
No,
but I have
not being shared.
I have shared my screen.
And Manju Bala has started screen sharing.
It is not visible on the.
I started my screen sharing. Should I
You
stop
again? Start. You stop sharing again. You start. Restart. You'll get it.
Is it visible now?
Yeah. Put it in slide mode.
Yeah.
Perfect.
Yes, ma'am.
Yeah. So I will be in this talk concentrating on what NACO has advised at country level for diagnosis in adults and children beyond 18 months and in children less than 18 months of age. So in adults and children beyond 18 months, it is regarding the detection of antibodies in the blood sample or serum or plasma samples. And if the results they are indeterminate, then to detect it either by viral or viral products. And in children less than 18 months of age, due to the persistent or maternal antibodies, diagnosis is made by PCR test. And also the diagnosis differs in children less than 6 months of age and in children between 6 to 18 months of age. I will be talking about that in the subsequent slides. So before we go to diagnosis, first we should be knowing about the classification of HIV because the diagnosis is dependent on that. That HIV is classified into two types, that is 1 and 2. And HIV-1 is further having 4 groups. That is HIV-1 major, O outlier, N that is non-M and non-O, and HIV-1P that is pending because only 2 cases they have been identified till now. So pending further confirmation for more cases. And in Western Europe and America and Australia, it is the subtype B, which is prevalent of group M. And in India, it is South Africa, and it is type C, which is more prevalent. As all the research, it is mainly focused on B subtype, and some research is being carried out on subtype C. So when I'm talking about diagnosis of HIV, I'll be talking about how to detect HIV infection, whom to test, how to test, what are the protocols or different strategies of HIV testing at country level, how to interpret the test results, and what is the national policy of testing. So when we talk about detection of HIV infection, clinical symptoms of HIV infections, they are not very clear cut that we can say that this is HIV infection. So, and in most of the cases, acute infection, it may be asymptomatic, and infection is silent until the last stages when patient presents with AIDS indicator conditions. So then the diagnosis has to be confirmed only in the laboratory by the laboratory test. That is why laboratory carries a lot of importance in diagnosis of HIV. So in the initial stages, when the person gets the infection, P24 antigen, it rises, and then it starts declining, and the antibodies, they start appearing from 3 months onwards, even sometimes at 6 weeks also they are available. And then this anti-HIV antibody we have to detect. And after that, in the later stages, the antibody, they may start declining or they may persist, and P24 antigen in the advanced stage of the disease, it again appears. So general principles regarding the testing, it is an overall comprehensive prevention program, and testing should be technically sound and appropriate, and results, whatever they are generated, they should be quality control results. And each and every test procedure, it should be appropriate depending upon where the testing is carried out, whether it is being tested in field or in laboratory. I'm not able to move my slide.
Just to press down. You have a control. Your PPT, you have a control.
I know, but I was earlier able to move down. It is not moving.
Ma'am, bottom right one controllers is there.
I'll stop sharing again and again do it.
Yeah.
So what is the purpose of HIV testing? That why the HIV testing is carried out? To prevent the transmission through any donation, prevent the transmission from parent to child, and it is to promote the voluntary counseling and confidential testing, which is being carried out in all the ICTCs, and also for diagnosis, staging, and monitoring of the HIV infection to enable the early detection and ART treatment. And when we have to estimate the disease burden, then surveillance is being carried out. And this STI surveillance is being carried out in country level since 1998. And in different risk groups and general population, it is carried out. And then different surveys, they are conducted to define the groups which need special attention, and also for post-exposure management in healthcare workers. So whom to test? It is in link to the previous slide that all the blood and organ donors, they should be tested. All those who are practicing high risk behavior, high risk, all STD cases, spouses of HIV positive individual, clinically suspected cases of HIV/AIDS. So whenever clinician they suspect in the clinic, they should accordingly send the sample to the lab. Children born to HIV positive mothers and contacts of positive cases. So contact tracing carries a lot of importance to prevent further transmission of infection. So different kind of tests they are available for detection, that is antibody detection, which is mainly carried out in children and adults beyond 18 months. And there are ELISA or rapid tests available. And they are also used for screening and confirmation. And if there are indeterminate results, then Western blot test is carried out. Then antigen detection test, they are not carried out because they are having very less sensitivity, that is less than 30%. So that is why they are not recommended for diagnosis. Otherwise, detection of viral nucleic acid, which can be carried out in children less than 18 months. I'll be talking about that. That is qualitative and quantitative. Virus isolation, it takes around 2 to 4 weeks. It is costly and it is done only in few labs. And then the surrogate markers like CD4 count to define the category of the disease. So different HIV antibody testing methods are available. ELISA, rapid test. Rapid tests, they are available on the basis of different principles, that is particle agglutination, enzyme immunoassay, immunoconcentration, that is vertical flow, immunochromatography, that is lateral flow. And sensitivity of all these assays as per NACO guidelines, they should be more than 99.5% and specificity more than or equivalent to 98%. So approach to HIV testing. Whenever we suspect that the HIV infection is there, then they are sent to the counseling center, and all testing should follow 5 C's of counseling, that is consent, confidentiality, counseling, correct test result, and immediate connection to the services for HIV prevention, treatment, and care. So in ICTC, first pre-test counseling is done when the client comes, and after the informed consent, if the test has to be carried out, informed consent is taken, and then the sample is collected for HIV testing. And after the test results, the post-test counseling is carried out in ICTCs. And if the case is HIV positive, then they are referred to ART for assessing the clinical and immune status. That is CD4 count is done and ART is accordingly advised, and follow-up counseling as and when it is required. So there may be false positive and false negative antibody test results. There are some conditions like in where we can see false positive results. That is autoimmune diseases, multiple pregnancies, multiple transfusions, hyper-agammaglobulinemia, anti-polyester antibodies, patients with hepatitis, or it can be due to sometimes technical error, that is some labeling error or something like that. False negative in window period. So that is why we have to see whether patient is coming in window period by taking the proper history. In late stage of disease, sometimes it can be positive. We have seen one case when I was in Safdarjung, that patient earlier was an HIV positive by antibody methods. But once patient comes positive, it is indicated they shouldn't be tested again. But somehow that patient sample was sent to us again. And when we checked, it was negative. And when we went into details, we came to know that the patient is in advanced stage of disease. It doesn't mean in every advanced case, antibody test will be negative. So sometimes we come across, then we have to be very careful while giving the results. And sometimes it can be technical error. So the antibody test, rapid tests, which are used as per NACO guidelines in all the settings, they are having a lot of advantages because we don't need any complex equipment for that. Small numbers of samples can be tested, and they are cost effective in small centers, and they are having very good sensitivity and specificity, and results they can be immediately revealed. And any person who can be trained, they can be used for this rapid testing. Only disadvantage is that if large number of testing has to be carried out, then they are time consuming, or they can be slightly more expensive than ELISA. Otherwise, considering the benefits, they are much more than the disadvantages. So if the results, they are indeterminate, then the Western blot test is done in the reference labs, that is state reference labs. And if the Western blot test is still indeterminate after 4 weeks, then it is confirmed by PCR at National Reference Laboratory. And PCR tests, they are able to detect 1 to 10 copies of the HIV proviral DNA. They are having good, very good.
Dr. Manju Bala, we are 3 minutes away from schedule. Please
Yes.
continue.
Yeah. So this is immunoconcentration, and this is immunochromatography. And when we have to interpret the result in the reactive test band and control band both are present, in non-reactive only control band. And if the sample is invalid, then it is repeated. And if problem is there, then again, we have to see that there is some kit problem. So testing procedures, they are unlinked, anonymous, voluntary and confidential, mandatory. Unlinked and anonymous, it is in surveillance, voluntary and confidential in ICTCs, mandatory in blood banks. So this is strategy 1 of HIV testing, which is used for transplantation safety or transfusion safety. Only one test is carried out. If it is positive, then it is blood bag is discarded and they are referred to the linked ICTC for confirmation. If it is negative, it is considered as negative. Strategy 2, where the 2 tests are carried out and it is for surveillance. In sentinel surveillance, this is being used when 2 tests are carried out. If first test is positive, then reported as positive. If first test is negative, report it as negative. And first test as positive, then again carry out the second test. Then it is considered as true positive. And if it is negative, then consider it as negative. Then strategy 2B, which is used for symptomatic individual. If second test is negative, then third test is carried out. If third test is positive, it is considered as indeterminate. And if second and third, they are negative, it is considered as negative. But again, it has to be evaluated whether it is high risk or low risk. Strategy 3, for the positive cases, 3 tests, they have to be carried out by different principal kits. Only then the result is given as positive. So internal quality control, it has to be practiced at every level, at the level of specimen collection, storage of specimens, during labeling, while performing the test, while using the controls, and while using the kits also. So IQC, it carries importance at each and every step. And when we are interpreting the results, there can be some pitfalls because patient may be in window period, or there may be false positive or negative results, or there may be discordant results. If there are discordant results in high risk, we have to follow up. There can be discordant couples, then we have to, retesting is required. And if still the contact is negative, then safe sex practices, they are advised. And testing of babies, I will be talking about that. So EQUAS is carried out to ensure the quality of the results. Proficiency testing, it is being carried out. That proficiency panel is prepared by the reference labs and then they are sent to the other labs. And then retesting every quarter, the samples, they are sent by the ICTC to the linked SRLs in the first week of the every quarter. And there is consortium of NRLs for checking the kit quality, and our lab NCDC is there in the one of the 4 labs who are checking the kit quality in this consortium. When we are talking about diagnosis in infants and children less than 18 months, then PCR test is recommended. But in less than 6 months, then early infant diagnosis protocol is used. So this is the flow chart I'll be talking because this is quite a bit lengthy. I'll be talking briefly in this slide that how we have to carry out diagnosis in less than 6 months. It is by PCR. And if test is positive by DBS sample, then another DBS sample. If repeat sample is positive, then the baby is considered as infected and the baby is referred to ART for treatment. If repeat sample is negative, then another DBS sample is taken. Then accordingly, interpretation is done. And if HIV-1 is not detected, then baby is asked to visit at 6 months age for the testing again. And if baby develops signs and symptoms in between any time. Rapid antibody test is not recommended in children less than 6 months of age. If baby is less than 6 weeks, PCR is not recommended because PCR sensitivity is quite less in less than 6 weeks. And if 6 weeks and above, then PCR is recommended.
Madam Manju,
Yes.
time up, I think.
Okay, just one slide. In children less than 6 to 18 months of age, in between 6 to 18 months, then the 3 antibody tests they are carried out. And if 1, 2, or 3 tests they are positive, then DBS sample is used for PCR testing. So that is very important in 6 to 18 months, that antibody test followed by PCR test. And for diagnosis of HIV-2 infection, there are differentiating kits available, which are used at ICTC level. So ultimately, HIV test, it is not done in routine because it has to be carried out wherever it is indicated. It doesn't alone never stops the epidemic. HIV test results is a snapshot of someone's HIV status today. There is no guarantee from being infected tomorrow. So HIV prevention rests on individual willingness. Thank you. Thank you so much.
Thank you. Thank you.
Rajeshri. Yeah, second chairperson.
Sir.
Second chairperson has to introduce the second speaker.
Yeah, that's fine. I'm waiting. Sir,
Dr. Tarun.
Mittal.
Tarun Mittal, sir, please. Umesh sir, you can call, I think.
If he is not there, sir, continue, sir. Ramanan, sir.
Ramahan.
I have great pleasure in inviting Dr. Jacob Maniar for his presentation on the latest guidelines for treatment of HIV and AIDS. And Dr. Maniar needs no introduction. He's a stalwart, and anywhere in India, just talk about Jacob Maniar, people will say he'll associate his name. And he has done a lot of cases. I've seen several thousands. I think it will cross even the year 2021 also. So Dr. Maniar is not new. Dr. Maniar is not new to this audience. I request Dr. Maniar to go ahead with his presentation. Thank you, sir.
Thank you. Yeah. Thanks. My sincere thanks to the organizer for giving me a chance to share my experience with you for last 36 years now. And I would like to say that I have a distinction of completing 1 lakh case in 36 years. And we have now 26,000 patients on ART under my single care. Globally, there are 38 million people living with HIV. The unfortunate part of the story is not everybody knows about HIV status. 79% knows, 62% on anterior therapy, 53% are virologically suppressed. New HIV infection has been reduced because of the antiretroviral therapy. What's the problem?
You have to share this.
1 minute, sorry. Why did you touch? Huh?
We can't see your presentation, sir.
Yes.
Yeah.
क्या है? तू सुकम हाथ लगा रहे हो?
Slideshow.
तू क्यों? अरे यार, तू यार, you have done a mistake. क्या तू कर रहा है यार? तो छोड़ दे तू. The epidemiology of India showing 2.1 million, the 3rd largest epidemic in the world. And I think it's an underreporting. None of my 1 lakh cases have been reported. There are several other colleagues of mine who have not done a reporting. In India, we know that there are around 79%, which again, I doubt the figure, know their status, 56% on ART, and the people who are virologically suppressed, or we don't know the exact data. The sexual transmission is one of the the main cause of transmission today. Like syphilis, it's a multi-system disease. You can't be just infectious disease doctor. You have to be intelligent physician, dermatovenerologist to pick up all this system when you see patient clinically and go ahead with the further management. These are all age-defining illness. I never saw any subject where you got something like disease-defining illness. And this is what you see, the big list of it, and something which I never saw before HIV era, the various list of diseases that you see, they're all my own collection. This is what I have seen throughout 36 years' time. The new advancement is you can treat cryptococcal meningitis with single dose regime rather than daily injection of amphotericin B with flucytosine and followed by fluconazole. A single dose, that is one of the advancement that the WHO has declared. What's the advantage of antiretroviral therapy, the revolutionary stage in the HIV medicine? The advantage is it cuts down the pandemic, it cuts down the morbidity, mortality, it cuts down the incidence of opportunistic event, it improves the quality of life, it extends the expectancy of life, it cuts down mother-to-child transmission, it's cut down, of course, sexual transmission, and of course, the socio-economic improvement you might see. As you say, the number of Asia-Pacific country, again, what you see here is India has 56% of people receiving the antiretroviral therapy. There's a big gap, and you can see the various countries have the very similar problem. People talk about NACO, which I'm not into the public-private partnership, but there are a good number of people, something like over 16 lakhs people under treatment with various NACO centers. There was a WHO target of 90% should be diagnosed by 2020, 90% on treatment, 19% should be virologically suppressed. But I don't think this target has, we failed to achieve the target. What India is, 79% of people are aware about their status, 71% are on the antiretroviral therapy, and we don't know how many number of people are virologically suppressed. I know what is the status in my private clinic of 26,000 patients who are on ART therapy. Over 85% are virologically suppressed. This is something unlike leprosy. I spent a lot of time in leprosy and look at the HIV. Every year there's a new molecule. Right from 1987 till today, you have a huge number of molecules available of various classes, of various potency, of varied side effects. What does the WHO say about when to start ART? I think ART should be started on anyone who is positive, irrespective of CD4 count, irrespective of viral load, and that is the saying today. Whether it's a children, whether it's a pregnant mother and breastfeeding lady, adolescent, infant, or whatever it is, who is positive, start off. And these are the various guidelines. WHO guideline and NACO guidelines are similar. What we are using now in ART center is DTG 3TC tenofovir combination. Alternatively, 400 milligram of efavirenz, FTC, 3TC, and TDF. In the Western world, they are using bactigravir as one of the first-line therapy, along with the TAF and FTC. There are various options available. Only my question is, if you have a patient who is on zidovudine, nevirapine, and 3TC, doing very well for last 18, 19, do we really need to change? My answer is no. There are various WHO guidelines as a preferred regime, as an alternative regime. We also have second-line treatment available, depends on what is your first-line treatment failing, but make sure before you switch, to think in terms of assessing adherence. Adherence is something which is very, very important. Same day ART initiation is like syphilis. When you see somebody with syphilis, diagnosed with syphilis, treat the same day with benzathine penicillin. The same way, there's a strong recommendation to start ART on the same day. These are the various drugs with different classes. There are quite a few in pipeline that I will show you, but this is a huge list in contrast to what is in the leprosy. Again, you can see the whole evolution. In 1983, we searched HIV right from 1987, single molecule of zidovudine. Now you have integral-based single tablet therapy. There are other new drugs. Now people are talking in terms of 2-drug therapy and different ways of delivery, injectables and so on, which I show you. What is most important is, if NACO says there are 60 lakh people being treated, how many people are retained in the care? Retention in care is the most important requirement for optimal clinical outcome of the patient with HIV infection. Please remember retention in care. Prevention of mother to child. Every mother who is pregnant, breastfeeding, and HIV positive should, without failure, without delay, to be initiated with antiretroviral therapy. That's the only way of minimizing transmission from mother to child. If you do not treat positive pregnant mother or breastfeeding pregnant mother, a breastfeeding positive mother, there are chances of 15 to 45% rate of transmission from mother to child. And if you give an effective antiretroviral therapy, you could almost bring the transmission to 0 level. I have more than 350 deliveries since last 5 years, and our transmission rate is 0. So remember the antiretroviral therapy in pregnancy and breastfeeding mother. Recommended therapy, suppose you've got a patient who's positive and become pregnant, so whatever stable therapy he or she is, continue it. Or you can today use even dolutegravir, tenofovir and 3TC combination, which is more or less safe. Again, what's the problem with the current antiretroviral therapy, mainly integrase inhibitor? Weight gain. Please remember, today the talk of the antiretroviral therapy field is weight gain. Almost every antiretroviral causes it, especially integrase inhibitor, number 1, and 2, the new molecule called TF causes more weight gain as compared to TDF. Despite antiretroviral therapy, people after starting antiretroviral therapy have an immune recovery and they still fall sick. It's called the reconstitution syndrome, which can occur at any age. It can occur after 4 to 8 weeks of therapy. And the number of percentage of people who get immune reconstitution syndrome varies, right from 5% to 25%. There's something like paradoxical iris, that is the worst, the current illness getting worse, or unmasking iris, that means appearance of the newly diagnosed OI after initiating ART. Please remember, as soon as the opportunistic infection has been treated and the treatment is well tolerated, you should start antiretroviral therapy, except in few cases such as TB meningitis, cytomegalovirus infection. One should delay the or cryptococcal meningitis, we should delay the antiretroviral therapy. These are the pictures of the immune reconstitution syndrome clinical pictures such as herpes zoster, leprosy, tuberculosis, lymphadenopathy, and HSV, or PCP, stematitis, progressive multiple leukoencephalopathy, or autoimmune thyroiditis. What were the causes of death before ART era? TB, non-tuberculous mycobacteria, PCP, toxoplasmosis. Now it's an anti-liver disease, kidney disease, non-Hodgkin lymphoma, heart disease, and so on. The important point is that what's happening with HIV in aging? Our aim is to suppress the viral load. All the people are now living with HIV and they're doing very well. But the life expectancy is almost 10 years gap, lesser than the general population. People still fall sick. Why? It's because of the comorbidities or non-communicable disease development, cardiac disease, cardiovascular disease, hypertension, non-age cancer, osteoporosis, kidney disease, cognitive decline, or a liver failure. There is an urgent need to integrate multispecialty treatment with HIV. Managing comorbidities involves drug-to-drug interaction. PEP is an emergency intervention to abort HIV acquisition, either due to occupational exposure or non-occupational exposure. It should be started within 72 hours. The drug of choice today is tenofovir, Aptisy, and dolutegravir, and there are various alternative drugs too. The risk of the risk is aborted after PEP up to 80% if well taken. Second point is, for a sexual exposure, if HIV positive SARS is documented to be undetectable viral load, there is nothing to worry about PEP. To tell Manju Bala to add to what she says, even the people seeking pre-exposure prophylaxis should be HIV tested. It's one of the best treatment today in absence of vaccine and cure to end HIV epidemic. It is a treatment that is given to uninfected individuals who are at high risk behavior. The drugs that is approved are two drugs called tenofovir and Aptisy, or TF and Aptisy. And now we have monthly injectable cabotegravir, rilpivirine injection intramuscularly, and make sure the people who are on PEP are well periodically seen. They have to be tested for STDs and HIV every 3 months so that we can intervene any progression. Undetectable equal to untransmissible. That's very important finding for last couple of years. And we have a project of offering parenthood to the discordant couple or a gay couple. And with a natural sexual relation, we are almost 320 couple, both serocordant and serodiscordant. None of the children are infected. And we have 5 gays whose semen was injected into the surrogate mother, and the babies are non-infected. We now think of 2 drugs. Why 2 drugs? Why not take 2 drugs when, if it works, rather than take 3 to 4 drugs, the less cost, fewer side effects, and you spare the menu. And nowadays it's an era to start dolutegravir, lamivudine, which is a non-inferiority viral suppression instead of 3 drugs or 4 drugs. Once the patient is virologically suppressed, you can switch over to 2-drug therapy, that is the dolutegravir and 3TC. Nowadays, there's a feasibility that even in a test and treat policy recommendation, you can start off with the DTG and 3TC as a first-line treatment. And during workout, if you find that the patient's got a transmitted resistance or hepatitis B co-infection, you can make the drug triple. There is nothing lost in that particular period. Or now, person who are on 3 drugs, virologically suppressed, can be given long-acting cabotegravir and rilpivirine therapy every month. This is one of the options. There are other 2 drug regimens are dolutegravir, rilpivirine, cabotegravir, rilpivirine, or islatravir and doravirine. There are now, you can use implant, you can use patch every year. And the last slide, what we have learned in last 25 years. ART controls viremia. It enhances immune function. It prolongs survival. It prevents HIV transmission. The current ART is potential, is tolerable, is convenient, and increasingly available. What are the challenges? Drug resistance, toxicities, cost. It doesn't cure HIV. Or life expectancy remains reduced on ART. Ongoing morbidity on ART. Funding lifelong ART is possibly unlikely. Thank you.
I request Tarun Mittal sir to continue the further proceedings, calling the moderator. And thank you, sir. Thank you, Mania sir, for the wonderful presentation.
Dr. Tarun Mittal and Dr. Shilpa, both. One will
Yes.
invite the moderator and other the panelists.
Mittal sir, are you there?
Unmute yourself. Tarunji, unmute.
Yes, I am there. Dr. Bhumesh. So at the outset, I would like to congratulate the whole team and Dr. Bhumesh for this wonderful conference. And it is a really good one. And established post-COVID. This is what I feel.
Sir,
With
your
these
voice is
words, I would
breaking.
request the moderator.
Yeah.
Problem. Hello?
Your
Are you-
voice
Carry,
is breaking.
continue,
Carry
continue,
on.
Tarun.
Okay. So I would request Dr. S. Murugan, sir, as the moderator. He is a consultant in sexual medicine and HIV medicine at Shifa Hospital, Tirunelveli. And he is a former professor of dermatology venereology at Mukambika Institute of Medical Sciences and a former professor STD, Government Mohan Kumar Mangalam Medical College, Salem, and at Puducherry. Has published more than 64 papers, has been an executive member of CSEPI, national president of IASTD, has so many laurels to his. I would request Dr. Murugan sir to kindly come forward for the moderating this session. Dr.
And
Murugan
Dr.
sir.
Sirubate will introduce the all panelists. Please go ahead. Srinivas, next panelist. Dr. Sirubate ji. Dr. Sirubate is there?
Sir, you continue. I think he.
Yeah.
Somebody is sharing the screen.
No, Sirubate is there?
Should I continue, Dr. Mumesh?
Yes, sir. Yes,
I
sir.
think you can go ahead. Sir.
You do one thing. Stop, Srinivas, stop sharing.
Yes, stop sharing. Now, shall I share?
Hello.
Yes. Now, am I visible?
Yes.
You can hear me?
Yes.
Sir, yes, sir. Continue.
Yes. Good afternoon, everybody. Thank you, the organizing team, for wonderful arrangement and giving me an opportunity for sharing my view also. And this session is going to be having clinical progression of HIV disease. One should understand the clinical course of any disease before going to management. If we are not able to understand exactly understand the whole process of the progress, if it is syphilis, if it is tuberculosis, if it is psoriasis, we have to understand the progression or clinical course of any disease. So this is the topic, and especially in HIV, it is a complicated one. So we are going to discuss about this clinical progression of HIV disease. And I am having wonderful panelists, 6 panelists are there. First panelist and Dr. Sudhakar Babu. He is a medical superintendent and professor HOD in academic coordinator in AIE Masar, Chittoor, and he is an ex-serviceman, and he is a wonderful. He has published many papers also. Then next panelist Dr. K. Mahadevan, and he is a professor and HOD in PhD Institute of Medical Sciences Research in Coimbatore. And he is a lifetime awardee of IASSTD and also in Coimbatore IMA, and he is a past president of IASSTD and AIDS. Dr. B.N. Reddy is another panelist. He is a professor of Medic City Institute of Medical Sciences and retired from Usmania Medical College, and he is a organizing chairman of PTCon previously. So he is also there with me. And Dr. Parthasarathi is a young man. The Deputy Director, Accelerate Project of John Hopkins Institute, Hopkins University School of Medicine, Baltimore, based in Telangana, the Hyderabad program. And he's very much interested in HIV prevention, and he's a specialist in program management and clinical monitoring. He's also with us. Dr. Rajesh Rajagopalan is a professor of and HOD in Skin and STD in Government G Road Medical College, Perundurai, and he is associate director for IGSTD and AIDS. Dr. Vasiki is professor of dermatovenerology in KPV Government Medical College, Trichy in Tamil Nadu, and she is also physician. She is attending every conference, and she is very much interested in HIV and STD. Now, before going to the subject, prevalence of HIV in Indian context. India has the third largest HIV positive population in the world, next to South Africa and Mozambique. Nigeria was in the second place. Now, the 2019 statistics says Nigeria came to fourth place, Mozambique. Between Mozambique and India, only just 1 lakh cases were different. Maybe India came once again the second rank as previously. So we have to be very careful when handling this disease and preventing aspect. Nationally, we estimated nearly 2.3 million cases. And they say ranges also. Annually, we are having nearly 69,000 cases HIV new infections. Now, my panelists, I am asking one question. Do you think this 2.3 lakhs, 2.3 million cases of HIV is true, or what is your opinion? Dr. Parthasarathi, you are in prevention. Dr. Parthasarathi, please.
Sure, sir. Thank you, sir. First of all, thank you, Dr. Bimesh and entire organizing committee for this wonderful opportunity. So basically, any chronic disease we can only go for estimate rather than any specific measures and so on. So that's the only reason why we have to rely on estimates. The question here is like, is the estimate accurate enough? The point here is, these estimates are based on UNAIDS approved strategy of spectrum modeling that uses AIDS impact model, which is generated which is followed across the globe by the epidemiologists. The nitty-gritties of this model is it uses the AIDS mortality, HIV-related mortality, segregated by CD4 count, segregated by age, and segregated by ART status, whether on ART or death happened without ART. In addition, it also segregates the data based on key population and children. So in that context, to estimate the disease prevalence or incidence in the community, they also look at the fertility rate, especially fertility rate of key population, that is high risk group, because in India, our epidemic is concentrated more among the high-risk population, including female sex workers, men who have sex with men, people who inject drugs, transgender population, and so on. And another limitation here is like most of the times these kind of models are based on the practice from Africa, not from any other continent, although there is some scope to integrate models from the learnings from India as well. And the other limitation is like we don't have key population estimate after 2008 and 9. That was the only time when we did, the country, India did larger estimate of the key population. But it is only regional exercises there. So these are all some of the limiting points of these estimates. But despite these limitations, all the data points, whatever program points, whatever available, sans the issue related to the quality of data such as duplication and so on. And again, as Dr. Maniar mentioned, the private sector data. These are all few additional practical limitations of these estimates. But despite all these estimates, the UNAIDS endorsed the model practically applies whatever is best possible with any given country to come out to do these estimates. So this is not only the issue of India, but also across the globe. So most likely for any program management monitoring, we have to rely on estimates, although we don't know exactly whether this is.
Thank you, Dr. Parsal. Yes, sir. More than technical, what is your general opinion, Dr. Vasi, madam?
Sir, as he and Dr. Maniar pointed out, I want to emphasize on private sector notification.
Yes, that's what I want.
Some HIV practitioners may notify the disease, but not all. So that is my opinion. NACO has built up this with the private and
correct. That's
program.
Rajesh.
Yes, sir. Like COVID, we have to have a formula for identifying and bringing it to the thing. And another thing is that the HIV epidemic, which is peaked in 2000, is declining over the years and stabilizing. And of course, there is a slight rise of HIV in the Mizoram, Nagaland, and Manipur as per the 2021 statistics. So definitely, we have to see to it that those cases are brought. And then except for that, those states which are reporting more, that is 55% are from Tamil Nadu, Andhra, Karnataka, Maharashtra. And they have seen that other states, there is a slight rise in the people living with HIV/AIDS. So we have to have a stringent measure so that our NACP is implemented well.
Ready, sir? Ready, sir? Dr. Mahadevan?
Sir, in spite of having this public-private partnership, I
Yes.
definitely say it's underreported. And even if they come forward, since it's a chronic disease associated with a lot of stigmatization, they don't come forward testing. Even if we test also, I don't know how many of you are reporting to the NACO. Example, now I heard Dr. Maniar's lecture, he has got 1 lakh cases.
Yes.
I don't know whether they all are reported to NACO or not.
Correct. Mahadevan, please. Yes. Last month, I have seen 4 cases, new case. In my OP, my place is not a cosmopolitan city. And this month I see 1 case. And Dr. Maniar is telling he's treating, already had seen 1 lakh cases. There are so many private practitioners handling HIV cases. All these cases are really included or not. It's a very doubtful thing. I think even though they have put, there is a range is there, they have put, even then it must be more than that it should be, I think. Next. WHO staging of HIV disease. This is the old staging, but it's no longer holds good because after the policy of treat all. So we are not bothering about that. But anyhow, the clinical progression of HIV is window of opportunity, window period, acute infection or primary HIV infection, clinical latency, and AIDS. The window of opportunity, that is 72 hours, when the organisms gets entry into either mucous membrane, through mucous membrane or the skin, and it's recognized by the dendrite T cells and taken to the lymph nodes and presenting there, and the lymph nodes is processed and enters into the circulation, and in the circulation it finds the CD4 cell, and transcription takes place and the integration takes place. This up to that it is entering into the nucleus and settled. Once settled means we cannot do anything. So up to that we can do. That is called as window of opportunity, that is 72 hours usually. So this is in that 72 hours, if we are giving PEP, we can modify the disease, but we are not going to touch window period, window of opportunity much. And we are going to discuss about the window period, acute infection, clinical latency, and AIDS much. So AIDS defining disease, as Dr. Maniar told, not only defining disease, AIDS indicators are there, AIDS letters are there, so many things are there. So according to the immune deficiency in the patient, the disease patterns differs. Normally, the CD4 count is anything range from 700 to 1200. If it goes below 450 and the patient manifests, and mostly the HIV manifestations are due to immune deficiency. So this is the, according to the immune deficiency, the disease advanced conditions are AIDS different diseases are coming. And window period. So window period is one of the things. Time taken by the body to develop antibodies against HIV infection. Any infection, the body will take its own time to develop antibodies. That is called its window period. Normally in HIV, it is around 4 to 8 weeks, and it may up to 12 months and never up to 6 months. Test, usually antibody tests we are usually do, point of care tests are cost simple enough and cheaper. So we are depending mostly on antibody tests. These antibody tests are negative during this window period. That is very important. So during blood transfusion or during transfusion, they used to screen the individual with the antibody test only. So in that situation, there is a likelihood of transferring when the patient is individual is in window period, they are infective and the blood will be transfused. The individual may likely to get the infection. Likewise, he may be able to, he is otherwise healthy, sometimes they may transmit the infection to others. Whereas the molecular test may be positive, that's also some difficulties there. A 25-year-old married man was brought to, unmarried man was brought by his mother, his father no more, and for the complaints of melancholy and depression with a suicidal tendency. Some noise is coming. And he had sexual intercourse a week back under the influence of alcohol along with his friends. Somebody told that she was HIV positive. He was crying in my OP. and he wants to get suicide, and his mother was very much upset. He was having severe tendency for suicide, and consoling was not effective. Somehow or other, I managed with the HIV, the DNA PCR test. I made him wait and convinced. Such a condition we will come across. The HIV phobia is very, very common. Nowadays, especially online also, we are getting daily, monthly 3 or 4 cases. Everything, touching, itching, and nail scratching, everything they are doubting. Am I audible?
Yes, sir.
Yes, sir. Continue. Yes, sir.
Some noise is coming. I will remove my, sorry, I will remove my, I think. So, he was, just by molecular test, I was able to convince him, but every panelist would have come across such a situation. What is your experience about this? Even the molecular test, that is a molecular test, HIV1 only will be positive. We have, if you want to rule out both HIV1 and 2, we have to go for separate PCR test for HIV1 and separate PCR test for HIV2. That is another thing. And also the molecular test also will be more reliable, even though it is become positive within 7 days to 10 days. And it may be more reliable after 3 to 4 weeks. The patient may not be able to wait at that time, till that time. So patient will be agitated. So many cases are there. What is your experience about these things, Dr. Parsari?
Yes, sir. So we have come across many such cases in my practice, as well as in during when I was in a government service, sir. The primary thing what we follow here in these cases are the counseling with respect to the suicidal ideation or tendency whatsoever. So that should be the primary thing. Even referral to psychiatric department, if the client is willing, will be the better strategy. And second, as you rightly said, the PCR test has to be done at least to give some kind of evidence-based counseling and guidance. But of course, we cannot rule out any HIV positivity within 6 weeks, even if it is PCR or whatsoever, P24 antigen and so on. So counseling and test with serial follow-up of antigen antibody tests should be the strategy in similar cases, sir.
Thank you, Parsari. Dr. Vasi, madam, what is your experience?
It's the same thing. I'm telling the same psychiatric counseling and referral to a psychiatrist if the patient is so panic. Because even with more sensitive assays, there is a blind spot in diagnosing immediately after a sexual exposure or take a needle stick injury. We cannot diagnose immediately after those events. So the patient has to wait for 3 to 4 weeks. Till that time, counseling will help.
The HIV phobia is sometimes very difficult to manage, and even they may not. Sometimes they may refuse to go to psychiatrists also when they're. And sometimes some other patients with the repeated counseling, they will be able to be pacified. Dr. Rajesh.
Single test is not enough to say actually in HIV medicine, any positive test should be again reconfirmed. Moreover, this is a DNA PCR whose sensitivity is less than 50%.
Sir, we know, but it is just to pacify him. We have to convince him whether it is enough or not, that is different. But we have to reduce his anxiety, tension. That is very important. That is Dr. Rajesh.
Yes, sir. This is a typical case of HIV phobia. First of all, we have to have a proper sexual history, whether he is having any previous sexual exposure and all. After that, anybody phobia patient, which is an illness anxiety disorder, referral to a psychiatrist should be considered only in the 3rd or 4th sitting. By the time we can tell the patient, and we can have a serial battery of tests, what I have told you. And then patient himself may know that it will be positive by 3rd week or 4th week, like that and all. So we can buy some time. Meanwhile, we can put the patients on some antidepressants and anti-anxiety agents ourselves. Otherwise, we can have a colleague side by, so that maybe in the next chamber, we can take the patient there and then do it. Instead of definitely referral, I don't do it at all. I take him to the clinic. He says that he is a bigger doctor. He will do much better counseling. By that, I have learned therapeutics as well as counseling also. So see, we can have to buy some time.
Thank you, Rajesh. Dr. Mahadevan?
Qualitative PCR, sir. It is not quantitative. We have to do qualitative PCR.
Yes. Dr. Mahadevan is there?
Yes, sir.
Sir, what is your opinion about this window period and HIV phobia, sir.
So, the phobia is always there. Even among the COVID period, people have gone to massage parlors and other areas, and now they are afraid that I have got a creeping sensation. Everything that, as you told, they are telling all sorts of things. But it is not only DNA PCR which is going to help him. We have to counsel him that this test, around 50% of the time, it may be positive or negative, we can take it. But anyhow, you have to go for the regular test afterwards. 6 to 12 weeks later, you have to go for that. We have to counsel, and counseling again. That is the basic thing. And it is still very difficult. We have to send them to the psychiatrist. And 90% of the patient will not go to the psychiatrist.
Yes, yes.
They will come back to you only. You tell, sir. So what I do in my practice is I show them the books, and this is what the book says. And we are following the books only. You just read that. And I will, with the book, I will explain. So now they are a bit okay. And the problem with many of the people is they go to the Google, they search for the symptoms.
That's another
only.
problem. Yes.
Symptoms only, they look for the symptoms, and they don't believe the blood test at all. They are oriented towards the symptom that aggravates the phobia. So that is the problem.
Yes. Thank you, Mahadevan. Acute infection or primary HIV infection or seroconversion. Usually the symptoms of primary HIV infection may include non-specific flu-like symptoms such as fever, swollen glands, a sore throat, oral ulcer, thrush, weight loss, tiredness, body ache, vomiting, or a rash. This is also called as seroconversion illness and usually occurs 2 to 4 weeks after the infection. Symptomatic seroconversion illness occurs in the 50 to 70% of the patient individuals, not with all. Immune system is weakened, CD4 will go down and viral load will be very high.
Others, please mute yourself, please.
Mostly it is self-limiting, resolve within a week or two. And but this stage is usually go undetected as these flu-like symptoms are common with many illness. We will not suspect primary HIV infection unless the individual reveals recent history. Present as an ordinary cold or sore throat, used to be treated with tablet paracetamol or sometimes at the next stage antibiotics. By the time we start investigating, it will subside. So the physician will forget and the patient also will forget. So usually go unnoticed. So what is your opinion about these panelists? Dr. Rajesh?
Sir, I have seen a case of 2-3 cases of acute HIV.
Very good.
First, actually, the patient was presenting as a rash. So at that time, he was in a private clinic. I diagnosed as a case of some evolving pityriasis rosea, and he gave history of exposure around 3 weeks ago. So it was, and then I instituted an azithromycin and topical emollients, and then asked him to bring back. On the third day, he brought with the test. So he had, because since he had 3 weeks of exposure, I advised him to go for qualitative PCR. Then at the time, it was not, CD4 cell count was quite good, sir. So second case was that he was from a house surgeon. After listening to the lecture from Dr. Mohan Kumar, he went and in a case of acute diarrhea in the ward, he elicited the history of exposure, and he came and asked me whether we can do the test and all. Since the patient was affordable, he could do, and then that patient also passed. So these are the 2-3 cases which I have seen. Sir.
Okay.
So only thing is that symptoms are non-specific.
Yes, that's correct. But whether we can confirm, this is due to acute infection, only with the history and other things we can do.
Yeah.
Mahadevan?
There are no specific signs and symptoms for.
Mahadevan, please.
I had a case last week, sir. Some 4 weeks back, he had a contact with a transgender, oral and anal both, insertive and receptive, all things. And he came with a sore throat. I thought about pharyngeal gonorrhea or something like that, or any chancre is there. I looked for those things. Then I sent the patient to the ENT department. They said nothing is there, mild congestion is there. He came back and ordered for DNA PCR as well as ELISA also I got, because he had previous contacts also 1 year back. So I ordered for ELISA also. Both came as positive, and he got only running nose and sore throat. We also did it for COVID also we did the test. It was negative. And this seeing
Thank
this
you,
as
Mahadevan. Dr. Vasi, madam.
Sir, I also had long ago, I had two patients. Those are marital partners of HIV positive individuals, and they presented with this non-specific symptoms only. But at that time, ART, that is the diagnosis after starting ART after diagnosis was not there. So
Yes.
I treated only symptomatically. And recently, I had an MSN, and he presented with flu-like symptoms, and I started him on ART.
Very good, madam. Sudhakar Babu.
Yes,
please
sir.
highlight your experience.
Sir,
Vasi, madam.
sir, I have seen.
Long ago, I had two patients. Those are marital partners of HIV positive individuals, and
Not heard properly.
presented with this.
Hello.
Yes.
Sir. Sir, I had.
Disruption is there. Ready, sir?
Yeah, it's actually very difficult to diagnose. And maculopapular rash, what we get as a viral exanthem in some cases, because of our skin color, Indian skin color, very difficult to diagnose. Even if you confirm with available tests, and only in two circumstances we can diagnose. One is a post-exposure prophylaxis, and another is in discordant couple where there is a transmission. So in two such situations, actually we should suspect and do the proper test, and we should start ART as early as possible once it's confirmed.
Sudhakar, want to tell something?
Yeah, yes, sir. Regarding acute infection, I had about 2 to 3% of my cases wherein they could point out the flu-like symptoms. So they keep on asking for the test. If we do it and say negative also, they will go to several labs and get it done.
Yes.
They won't believe you because they Google it so much that it gets into their brain that they are having disease. So as you said in the first slide, so we have to sometimes to get the test done, antigen PCR screening test for pro-DNA or DNA, and then convince the patient, ask him to come back again. We should not leave the patient unless we have the confidence that patient is following and having confidence.
Okay, we'll have some other case. Sir, you told something about some case, some test is there to detect earlier rather than the DNA PCR. Is there anything like that?
Yes, sir. So there are two kinds of, one is practical modality, other one is emerging research-based modality, sir. Practically what British guidelines and other people say is like, when you suspect this kind of acute HIV infection or so-called primary infection, they say qualitative test to diagnose HIV and then antibody test also along with viral load test. So if somebody is positive with antigen or qualitative PCR, with a high viral load in a quantitative PCR with absence of antibodies, that means that that individual fits to the diagnosis of, as per laboratory diagnosis, fits to the category of primary HIV infection. And we have to treat the individual at the earliest with highly active antiretroviral therapy, sir. This is regarding the practical modality, but right now, CDC and other global bodies are coming up with a test called recency testing. So testing, basically, it depends on the avidity of antibody. See, technically, I'm afraid to talk about microbiology in front of stalwarts like Dr. Manjuwala. Just a quick line. Avidity of the antibody means a binding capacity of the antibody. The older the antibody, the better the binding capacity with antigens, so that it will form a strong antigen-antibody complex. Whereas recently developed antibodies, they don't have that kind of binding capacity. So we use limiting antigens to detect those recently developed antibodies. If a person is having antibody of a recent development, not of a chronic antibody with high avidity, that means this is recent infection. That is called recency test. And Stadia and Maxim are two brands available right now, but still they are not available commercially. It is still available in the
very informative
purpose.
Thank you, sir. We will lack of time will rush.
Sure, sir. Thank you, sir.
25-year-old lady got married just 8 months ago. Till then, she was very all right and had suddenly developed fits, became unconscious 1 month back and got admitted in a corporate hospital in Madurai nearby my place. And after 1 month, she brought to my place and she was unconscious. Reactive for HIV1 and viral load was 285,500 copies. Western blot reactive for HIV1. CD4 count 254 cells. Antibodies against CMV, HSV1, rubella were detected both in blood and CSF. She was started on ATT ganciclovir in the mother itself. It's the previous hospital itself. Patient was on ventilator for 3 weeks and she had respiratory failure because she had respiratory failure. Ganciclovir stopped after 3 weeks after coming here because severe neutropenia was there. Patient was put on tablet valciclovir 1 gram twice daily, and response to painful stimuli was present. Response to commands variable and unpredictable. She was respond to only to her mother's command, not anybody else. But she was not at all respond to other thing. Patient was put on valciclovir tablet, cotrimoxazole, ATT through Ryle's tube. Patient succumbed to death without responding to drugs after 2 weeks. Prior to the date of her illness started, she was healthy, absolutely healthy, active as per her relatives. No obvious history of previous illness. Her husband was reactive HIV1. He is in a stage of refusing and not cooperating. He is not ready for any other test. He looks otherwise healthy. His attitude is denial. And in the previous treated corporate hospital, her condition was suspected to be CMV encephalitis, and they started ganciclovir as a presumptive and also presumptive ATT. There was no response to ganciclovir or ATT. Instead, ganciclovir toxicity made her worse. Her parents were non-reactive for HIV and they are healthy. Now, panelists, what are the possibilities in this case? Dr. Vasi, madam?
This could be, as far as I know, I am not a neurologist, this could be a HIV meningoencephalitis. Acute infection may present, rarely may present like this.
Yes, acute infection so severe. We used to come across flu-like syndrome, rashes, but such a severe syndrome, could it be acute infection? Because no other way. She's recently married, recently exposed. Dr. Mahadevan?
She may be a rapid progressor sometimes. Sometimes because it is a...
Mahadevan, your voice is little low.
I think now it is okay.
Yeah.
Yes, sir.
Yes.
It may be an acute HIV infection because it is a neurotropic virus. Even in the first stage itself, it can be a neurological manifestation.
Direct AIDS virus infection. Okay.
Yeah, sometimes it can happen. Otherwise, it may be a rapid progressor going for these things.
Yes.
That is another thing.
But one more thing, the presence of HSV1, CMV, rubella antibodies, usually many of us will have. If you have been tested, madam, you are a physician, you may be telling more.
Antibodies commonly present, antibodies to all this are commonly present. Only if we deduct the DNA PCR of these ages, it is confirmative.
Reddy sir, want to add anything?
Yeah, as we advance in age, we become positive because of all these viruses you mentioned, CMV, HSV1, and definitely I will consider ART treatment, thinking it's a acute HIV infection.
Toxoplasmosis cryptococcosis has not been ruled out in this case because she was very ill. We have not able to transfer to MRI. Dr. Sudhakar, want to tell anything?
Sir, yes, sir. I have to say that firstly, precocious AIDS is known for all of us. Precocious AIDS.
Precocious syphilis, like precocious syphilis, precocious AIDS.
Okay. And secondly, they might have the test was not done prior to marriage, so we don't know when was she infected. So husband is just positive, whereas the wife has developed all the rapid progressor symptoms and she died. So maybe PMLE, progressive multifocal leukoencephalopathy, associated with cryptococcosis or CMV meningitis. These are all the things which may be there. But we cannot rule out the infection before marriage. That's one point I would like to stress.
Okay. Good. Rajesh, want to tell anything?
Yes, sir. Yes, actually, I agree with Dr. Mahadevan, sir, as it's a case of rapid progressor. And also, she can be rapidly deteriorating in the acute stages. The viruses like Epstein-Barr virus, cytomegalovirus, and bacteria like treponema and tuberculosis, these organisms, they get triggered or activated in the stages. So they could act as a co-pathogen in mortality and morbidity of acute HIV, sir.
Yes, that's possible. But what is the thing which can trigger? That's also we have to look into. Okay, we will see. Rapid progressor are defined as progression of HIV infection into AIDS within 3 years. So, okay, this is a possibility. Another case, that is a middle-aged man, male patient who was on ART treatment, suddenly developed fits, unconscious, disorientation, MRI suggestive of, that is a progressive multiple leukoencephalopathy. CD4 count was above 500, that is 500 cells. We lost this patient also. Usually PML is one of the AIDS defining disease. And another case also we have seen PML and that's what 400 cells per cubic millimeter. Usually that PML is caused by JC virus, John Cunningham virus. And this John Cunningham is not a doctor, he is a patient first who suffered from that. And is no specific treatment, only the ART and the immune boosting only is a correct treatment. And but in this patient, what is important is usually PML is a AIDS defining disease, usually occurring when the virus CD4 cells below 100. But here, these both patients, we are getting the CD4 cells more than 400. So some patients, other AIDS defining diseases also, sometimes we get patients who are having CD4 count more than 350. This is also one of the puzzling thing. I think, what is the opinion of panelists? Dr. Mahadevan?
Usually, you have not mentioned how long he is on ART and other things. So we don't know how long the patient was having the infection. To PML to occur, it should be a very long period classically because the CD4 level has to come down. But here the CD4 level is not bad. And still he has developed this thing. So
yes,
maybe
rather than duration, the CD4 count only will be usually a marker.
That is the only marker available now. So again, he may be a rapid progressor and the CD4 count has suddenly dropped and he has developed a PML.
Rajesh?
So,
actually, I agree with Dr. Mohan, sir, Dr. Mahadevan, sir. It could be a case of rapid progressors, sir. So we have several type of progressors like slow progressor, long-term non-progressor.
Yes, I will show. But
yeah,
rapid progressor, the CD4 count should come down. The CD4 count remains good and progressing to AIDS defined disease is a controversy. That is a paradox. Not Vasi, madam.
In the post-ART era, AIDS defining diseases are occurring at a higher CD4 count. That is something.
Yes.
This is your experience or coming up with any literature?
Experience, sir. I have studied and I have told that.
Okay. Sudhakar?
Yeah, sir. Sometimes the virological failure due to the resistance developed for the regime. So that is one thing. So the treatment which was being given may not be sufficient to control him. And as my predecessor said, it may be rapid progressor also, very rapid progressor. But there must have been some comorbid condition which has caused this.
Okay, next case.
A quick point to add, sir, Murugan sir. See, always we bother about the quantitative CD4, but we forget the quality of the CD4 as well.
Okay.
Quality as well with respect to cytotoxicity and things like that, sir. So
competent, the T4 cells are not so competent enough.
Yes, sir.
Okay.
Sir, one more thing. CD4 count, diurnal variation is there. So at the sometimes it varies due to spurting. So we cannot take one test as the standard test. That it might have been gone to 200 also. 500 is one test, one time.
Usually the spurting or blips are just 50 cells, not more than that. Yes, okay. That's we'll go to next case. 43-year-old male found to be HIV reactive while trying for an immigration clearance at his age of 22 years, confirmed by ICTC in 2002 and 2003 by ORG Care Chennai, and he was promiscuous previously. And he was he's a state level kabaddi player in 2000. During 2000, he is a leader for Positive People Network since 2003. His CD4 count is during 2004 was at 1276, and he at that time he was not fit for ART because treatment was not there at that time. He married a HIV positive woman. Previously married, that lady was married to another man and having 2 children for her first husband, and during that was during 2006, and she also positive for HIV-1. She was on ART since 2003. Prior to that is in our center, we government national rollout from 2004 only came. A sample program started Tambaram in 2003 itself. She had 2 children for her first husband, and they have 1 child and born to them, and the child is also non-reactive, and that a man is practicing unprotected sex till date, sometimes coitus interruptus as a measure of preventing further conception. Her CD4 count is maintained above 700. Her viral load remains undetectable. This man remains CD4 count remains more than 800 always. That is in the 2018 898, 2019 1100 and 1297, 2921 and 21,397, and his viral load is 3,671. So 22 years after this infection, and he was not on ART, and he is maintaining the CD4 count above 3,000 cells. Every parameter, other CBC and other things, WBC count is 11,900. That is a differential count, a lymphocyte 32%, and everything, that is hemoglobin was normal, everything was normal. Every one of us treating so many HIV patients in since 3 decades, we had seen patients manifesting symptoms after 7 to 10 years or more, and some instances even 13 to 15 years. But we observe all these cases slow and steady decline of CD4 cells as a rule. But those manifesting symptoms after 12 to 15 years are called as long-term non-progressor. But in this case, the individual remained immunocompetent with a normal CD4 count even after 21 years with taking ART. That is called as elite control. Elite controllers are HIV positive subjects who control the viral replication without antiviral therapy. The subsets of elite control was further distinguished viremic controller who is having mild viremia.
Dr. Murugan, just a reminder, you're 5 minutes away from the scheduled time.
Oh, different controllers are there. Elite control, viremic controller, exceptional. That's a viremic controller. That's how it is possible for some. They remain without ART, without taking anything, and remaining immunocompetent for very long time. Is there any possibility?
Sir.
Yes. Yes, they may be having potent T cell responses, and also the physical and mental well-being and nutrition is very, very important. And they may have some genetic factors behind this also.
Yes, yes. All the individual is having detectable viral load in this blood. We cannot tell them labeling as sterilized cure is functional cure only. These patients are supposed to have protective HLA alleles, potent T cell response, as Dr. Rajesh told. Multiple factors, the viral factors also there, and these are the factors. Long-time non-progressor. And another girl I have seen that is in utero transmission. That is another case. Sorry, 28 years old man referred to me for HIV positive with extreme cachexia, oral thrush, thin build, difficulty in move about, and he is an engineering graduate. His parents were no more and said to be died of HIV 10 years back. Possibly he acquired it through mother-to-child transmission. Patient was detected to have HIV infection during 2008, but was multivitamins and is cotrimoxazole. ART started in 2018 with the TLE, tenofovir lamivudine efavirenz combination, etc. But he was not at all taken a single pill. Attitude of denial, refused to believe, thinking all the drugs are bad. Before got admitted into the hospital, due to sickness, he was taking it for the 15 days off a tablet, off a pill, and he had broken all the tablets into off, and his CD4 count was 30 cells and viral load was more than 6 lakhs copies. Extensive oral thrush was present, and the patient was in utero transmission. HIV positive individual can pull off his life 28 years without taking ART, and disbelief denial status for the refusal of treatment. Modification of treatment on their own, believing all the drugs are. Can we call him as a long-term non-progressor? Rajesh?
Sir, we cannot say like that because now that he is deteriorated, and of course, since actually the
till 28 years, he was not taking treatment. Now only he had very bad shape. Vasi, madam?
Yes.
Yes, sir. We have come across cases like this, not up to 28 years, cases diagnosed at 25 years, vertical transmission like that we are having, but the rate is less. But long-term non-progressors can have vertically transmitted people can be a long-term non-progressors.
Oh, that's correct. Parthardi?
Yes, sir. Like a similar discussion what we had in the earlier case, this patient also may have mutations related to surface antigen or HLA allele or to the viral fitness. So this may be one of the reasons why he's progressing very late.
So another girl also 17 years old and remaining hale and healthy was seen 12 years back, not now. 500 cells at that time, treatment policy was not there. I don't know, she lost to follow. So more HIV, that is a empty city patients remaining healthy for longer time.
Sir, we cannot generalize like that, sir, because childhood.
Many. Mahadevan?
Many of the empty city babies who are positive, I have seen them to develop symptoms very late only. I have been wondering actually what happens to these children.
Yes.
Previously, we were telling they will not cross the primary school. Now, sometimes we are identifying the patient after 21st year when they are getting married. They are found out to be thin. Then they say, my mother died of HIV and other things. This is happening on and off now. So there is something beyond our allele and other things,
yes,
especially for these girls who are boys and girls born to positive people. We have to find out the cause.
Next case, 49-year-old, recently started on ART. Government ART center came with complaints of intermittent fever, severe vomiting, dehydration, and just 8 days ago, he was thin built and found with mild oral thrush. Give me 5 minutes. CT thorax and abdomen revealed both pulmonary tuberculosis, extrapulmonary tuberculosis. ATT was started along with the ART, and tenofovir, lamivudine, dolutegravir, that is he was put on along with the ATT, and that is the dolutegravir 50 mg BD dose. He has his wife who was free from HIV. 2 children were non-reactive. He denies extramarital or premarital heterosexual relationship, but MSM relationship 20 years back he was having. CD4 count was just 37 and CD4 7.4. He was on ATT, but he was given DTG 50 mg dose. In this patient, efavirenz combination would be a better one. This patient knew his HIV status since 12 years, but he does not reveal to anybody. Got married and had children in spite of working with the NGO who caters for needs of PLHV and HIV positive patient. Only he felt sick. Severely he sought help of and started treatment. Fortunately, he recovered from with PPA and antiemetics, so he was discharged. Now switchover was not necessary. In this case, his wife was non-reactive. Zero discordancy is nearly 30 to 40% of the cases remain zero discordant. Why some remains zero discordant in spite of sexual contacts for years? In this case, vomiting may be due to irritants, gastric irritants may be there. So what is the zero discordancy is an important thing we have to talk. Dr. Vasi, madam?
The explanation could be already discussed, sir. So they are immune competent to the infection, HIV infection, or immune resistant. So even after unprotected sexual intercourse, they are remaining.
Anything else?
No, sir. Nothing. Madam, what she has told, I agree with.
Mahadevan?
It is the viral load in the source positive patient that also should be counted, and the frequency of the sexual contacts between this husband and wife, that should be done, and the natural immunity of the lady, that has to be considered. So all these multiple factors are going to work
for the felicitation of the
regarding the transmission from the husband to the wife.
Sudhakar?
Sir, apart from the statement given by my predecessors, I have to say one more thing. That is, some people, less than 5% of the infected people, they don't have CC or 5.
Chairpersons ani వాళ్ళ పేర్లు invite చేయి.
So such people will be having a virus in their body till they die because they cannot replicate. So, but they can transmit during that short time, but they will not suffer from the disease.
Good.
Recorded, sir. So, and now that Meravirak, such things, Vicrylic, they have come for even subsiding the CCR5 and CXCR4.
Okay, we'll finish. Carry on. Carry on.
Yeah.
Thank you, Sudhakar. You are correct. There are lots of mystery, even the natural progression and course of HIV disease yet to be revealed and understood. Some rapid progressor, many are chronic progressor, long-term non-progressor there. Few are elite control, viremic controllers. Some progressor faster than source, their source of the infection. Some are able to remain zero discordant. When all these things can be understood, we may be able to achieve a sterilized cure even with the HIV disease instead of functional cure. Just to follow your patients carefully. Maybe you are the one to get the knot release and throw more light and complete cure. Thank you very much. Sorry for delay in finishing it. Thank you very much. Sorry. Thank you, panelists.
Thank you, sir. Thank you. Thank you very much.
Thank you, sir.
Sorry, I am not giving all of you due importance because of lack of time.
No problem.
No problem, sir.
Thank you, my co-panelists.
Stop sharing.
Yeah, now, thank you, sir. Thank you very much for the wonderful session with a lot of take-home pills. Now it is a time to sensitize our postgraduates. For this, I invite the quiz master, Dr. Satyasree. She is associate professor from Gandhi Medical College, and she has 9 years of clinical experiences, and she has a vast experience in the field of DVL. So over to Dr. Satyasree.
Thank you, Bhumesh sir, for the kind introduction. Now, best of luck to all the postgraduates. So now I'm going to tell the instructions. So each session will have 10 MCQ questions. You should answer one correct answer, and the first 3 toppers will be selected for the first, second, and third prizes. The duration is for just 5 minutes. The postgraduates has to submit a bona fide certificate from the concerned HOD if they get the prize. And the quiz master's decision is final. And please don't refresh or close the browser. And best of luck, PGs. Go ahead. Yeah, thank you.
She is associate professor from Gandhi Medical College, and she
Glad
has
to meet you, sir.
medical experiences, and she has a vast experience in the field of DVL. So, Srinivas,
Yeah, you quiz, Srinivas.
Hi, Dhruti. Yeah, Dhruti.
over to Satyasree.
Yeah, now the felicitation starts. Yeah, I request the chairpersons to felicitate chairpersons Dr. Ram Manohar sir, Dr. Tarun Mittal sir, and Dr. Deepak sir to felicitate the moderator and the panelists.
And the speakers.
Dr. Manjubala ma'am, first speaker. Dr. J.K. Maniyar sir. Dr. Panelist Dr. Sudhakar Babu sir. Dr. K. Mahadevan sir. Dr. B.N. Reddy sir. Dr. M.R. Pardasarthi. Dr. Rajesh Rajagopalan. Dr. S. Vasiki ma'am.
And Quizmaster Dr. Satyasree.
Thank you, sir. And now I request the organizing committee to felicitate the chairpersons. Dr. Ram Manohar sir. Dr. Tarun Mittal sir. And Dr. Deepak sir. And thank you for the organizing committee for giving me opportunity. Thank you very much. Over to Dr. Bhumesh sir.
Yeah. Thank you, Dr. Satyasree.